Diseases of ear, nose and throat and head and neck surgery by P L Dhingra. Chapter 95, Adenoidectomy. Adenoidectomy may be indicated alone or in combination with tonsillectomy. In the latter event, adenoids are removed first and the nasopharynx packed before starting tonsillectomy. Indications: 1. Adenoid hypertrophy causing snoring, mouth breathing, sleep apnea syndrome, or speech abnormalities, that is, rhinolalia clausa. 2. Recurrent rhinosinusitis. 3. Chronic otitis media with effusion associated with adenoid hyperplasia. 4. Recurrent ear discharge in benign CSOM associated with adenoiditis or adenoid hyperplasia. 5. Dental malocclusion. Adenoidectomy does not correct dental abnormalities but will prevent its recurrence after orthodontic treatment. Contraindications: 1. Cleft palate or submucous palate. Removal of adenoids causes velopharyngeal insufficiency in such cases. 2. Hemorrhagic diastasis. 3. Acute infection of upper respiratory tract. Anesthesia, always general, with oral endotracheal intubation. Position, same as for tonsillectomy. Hyperextension of neck should always be avoided. Steps of operation: 1. Ball-Davis mouth gag is inserted. Before actual removal of adenoids, nasopharynx should always be examined by retracting the soft palate with the curved end of the tonsil tongue depressor and by digital palpation to confirm the diagnosis. To assess the size of adenoid mass and to push the lateral adenoid masses towards the midline. A laryngeal mirror helps to assess the size and extent of adenoid mass. 2. Proper size of adenoid curette with guard is introduced into the nasopharynx till its free edge touches the posterior border of nasal septum and is then pressed backwards to engage the adenoids. At this level, head should be slightly flexed to avoid injury to the odontoid process. 3. With gentle sweeping movement, adenoids are shaved off. Lateral masses are similarly removed with smaller curettes. Small tags of lymphoid tissue left behind are removed with punch forceps. Take care not to injure pharyngeal ends of eustachian tube. 4. Hemostasis is achieved by packing the area for some time. Persistent bleeders are electrocoagulated under vision. If bleeding is not controlled, a postnasal pack is left for 24 hours. Endoscopic adenoidectomy. These days, adenoids can be removed more precisely by using a debrider under endoscopic control or by coblation technique. The latter uses radiofrequency currents to create a plasma field which dissociates molecular bonds. Post-operative care, same as in tonsillectomy. There is no dysphagia and the patient is up and about early. Complications: 1. Hemorrhage. It is usually seen during the immediate post-operative period. Nose and mouth may be full of blood, or the only indication may be vomitus of dark colored blood which the patient had been swallowing gradually in the post-operative period. Rising pulse rate is another indicator. Treatment is same as for preoperative hemorrhage. Postnasal pack under general anesthesia is often required. Injury to eustachian tube opening. 3. Injury to pharyngeal musculature and vertebrae. This is due to hyperextension of neck and undue pressure of curette. Care should be taken when operating patients of Down syndrome, as 10 to 20% of them have atlantoaxial instability. An X-ray neck is in extension and flexion should be taken to rule out atlantoaxial instability. 4. Greasel syndrome. The patient complains of neck pain and develops torticollis. Mostly it is due to spasm of paraspinal muscles, but can be due to atlantoaxial dislocation requiring cervical collar and even traction. 5. Velopharyngeal insufficiency. It is necessary to check for submucous cleft palate by inspection and palpation before removal of adenoids. 6. Nasopharyngeal stenosis. It occurs due to scarring. 7. Recurrence. This is due to regrowth of adenoid tissue left behind. Adenoidectomy. Thank you.